Not there. So then yeah, we'll have an presentation by Dr. Virender. He's going to tell us about a case of coexisting myasthenia gravis and idiopathic intracranial hypertension. No, I'm sorry. Yeah, sorry, that's it.
Thank you. Thanks, Dr. Rohit and everyone. So it's an interesting case that we saw. This is a 38-year-old lady who presented to us, referred from the neurologist as a case of bulbar myasthenia and suspected papilledema. The past history was significant for migraine headaches from childhood, and the other significant history of COVID infection 4 months prior, which was confirmed by RT-PCR on throat swabs. For the COVID infection, it was treated with home care and there was no hospitalization. So we did not have the other biological markers at that time. At this point of time, when she came, she also gave history that 3 weeks prior she started having facial weakness, hoarseness of voice, difficulty in chewing, and dysphagia. She started having headaches 20 days prior, and the fundus had been seen by neurologists who suspected papilledema. The working diagnosis of neurologist was bulbar myasthenia papilledema and was suspecting a raised ICP. So the neurologist had already made our job easier. After suspecting this, he had obtained a neuroimaging, repetitive nerve stimulation test, and a thyroid profile. The MRI of the brain did show signs of increased intracranial pressure like partial empty sella. We also have scleral flattening, and the MRV venogram was normal, suggesting no cerebral sinus venous thrombosis. What else was done was repetitive nerve stimulation test, which showed a positive decremental response, and the thyroid profile had shown a partial hypothyroidism. Sorry. So with this, the patient had already been started on pyridostigmine, prednisone for managing the myasthenia. The patient was on tablet acetazolamide, assuming that it is IAH, and the suspicion of papilledema was to be confirmed. So when we saw the patient, very good visual function with 20/20 visual acuity. There was mild ptosis, fatigue test was positive, but rest interior segment was normal. Of note, the patient was moderately built with a BMI of 29. So this is a 9-gauge photo. We can see that extraocular motility was full and free, but what we can see is that there is a mild to moderate ptosis in both eyes. And the fundus examination did confirm presence of papilledema in both eyes. Given this, we obtained visual fields which showed enlargement of blind spot in the right eye, and in the left eye there was a few depressed points along the blind spot in the left eye. So we were working with the diagnosis of bulbar onset myasthenia, bilateral papilledema, a patient who is COVID-19 recovered, also has hypothyroidism. With this, the next step was to confirm that whether this is seropositive or not, because our management might be based on that, and the serum ACH receptor antibodies were positive. So it were highly positive actually, and then we wanted to confirm that is there definitely a raised ICP. So we obtained lumbar puncture. CSF analysis was normal, and CSF opening pressure was 24 centimeters of water. So it was just little less than 25. So we kept a we looked at the diagnostic criteria and kept it as probable IAH with all the radiological criteria being met. Having seen this, we were managing the patient who is seropositive for myasthenia papilledema. So we were looking at two things. One was, is there any previous association which is reported? So we looked at the only association is with the Castleman disease, which is a rare lymphoproliferative disorder, and there is a giant lymph node hyperplasia. It can occur in two forms, unicentric and multicentric. Majority of them do have a lymph node enlargement on the CT scan of chest. We did obtain a CT scan chest which was normal. We also looked at what can be the other mechanisms of both of this. So unifying mechanism has been proposed where both IL-6 and VEGF have been increased, and we looked at the further workup of the patient. We went, as the CT scan chest was normal, we were not looking at thymoma, we were not looking at Castleman disease. So what could still be unifying? So we are looking at COVID-19. Could COVID-19 be causing both? There are enough reports which tell that COVID-19 can precipitate myasthenia. Majority of them have ptosis, dysphagia, diplopia, and the postulated mechanism is break in the immunologic self-tolerance and the molecular mimicry that leads to increased levels. And then papilledema can also occur in COVID-19, there are enough reports which describe increased association postulated to be due to either a hyperviscosity, reduced venous drainage, or uh, increased venous pressure. So that can cause a papilledema. So we thought that possibly COVID-19 precipitated everything. The only factor was that the time gap was of about 4 months. Can it still be? Possibly. We don't know, it was diagnosed before. The other challenge was how long we can use steroids, because steroids can also lead to worsening of the papilledema. So we went back, we tapered the steroids and managed the patient on azathioprine, and over a period of time, as we can see here from the presentation, to subsequent follow-ups, the patient disc edema resolved and the ptosis also resolved. So this was the story of the patient. Thank you.
Thank you, Dr. Virender. A very interesting case. The acetazolamide was on the lesser side.
By the neurologist.
Yeah, they of course believe in homeopathic levels. They are, I don't know why, always very ginger in their dosing of acetazolamide. But yeah, I guess very interesting. Yeah, again led into the idea that probably it could be just coexistence of two different diseases also, or else COVID. But again, it's very difficult to confirm either.
Yes.
But yeah, it can be a challenge managing both of them, because you need to early taper the steroids so that you do not have hassles in managing the IAH. But thank you, Dr.
Thank
Virender.
you.
That was very interesting. Any comments?
Yeah, I think most of the neurologists, they would do that dose, especially when the CSF pressure is
Yep.
it's like a
Borderline, yeah.
And I have seen couple of patients. I think we had seen a series of 4 patients who had been OMG and then the COVID-19. So that is kind of the self tolerance, but this is quite rare. Like it could be anything. Like it could be a coincidence, but if both diseases together with the two different sort of mechanism that COVID is causing, this is something interesting. We can think about publishing or something.
Absolutely. I think that was a very interesting case. Thank you, Dr. Virender.
Thank you.